soft tissue situation, implant site problem, and also poor hygiene, dentist-related and host-related problem, and the potential of pathological tissue destruction, gingiva in the gingival level and peri-implant bone level might occur. So implant overdentures lose retention after a period of use, but usually patients have some same degree of comfort with both attachments when they're compared in studies. Rotation of the prosthesis with ball and bar attachments during mastication is compared in a study, and there are easier rotation and lateral rocking seen with the bar and clip attachments compared to two independent ball attachments. There is less rotation with the two independent ball attachments because clips were more closer to each other and ball attachments has a longer distance between. So cantilevers. Implants are splintered to cantilevered implant over dentures, usually in the mandible. Cantilever creates horizontal level forces. Anterior-posterior distance is the most significant factor to determine cantilever length. And cantilever length at most may be twice as much as the AP distance, but not in all cases. We have to look the arch form. As you see here, the oval arch form has 6 to 8 millimeter AP distance, square arch form 2 to 5, and V arch form has 8 millimeter AP distance. So longer cantilever bar can be made with a V-type part, such as 16 millimeter, twice as much as the AP distance. Hidden cantilever, another problem. Why a hidden cantilever may be destructive? Because it magnifies the cantilever forces if no denture movement. Denture base that extends beyond the cantilever bar with teeth in occlusion is a hidden cantilever. If you have a teeth right here in occlusion, that means you have a hidden cantilever bar because the bar ends here. What we should do is we can have a shortened dental arch, you can remove teeth right here or remove it from the occlusion. Crown height space is another problem. Crown height space is vertical cantilever and magnifies the forces with the horizontal cantilever together. Silicone index or put index used after teeth set up to evaluate the crown height space. I usually make a first denture, set of denture to my patients, and then I get a put index and evaluate this crown height space distance. At least 12 millimeter from soft tissue to occlusal plane is needed for implant over dentures. As you see here, we need 8 millimeter for the teeth and the acrylic, at least 3 millimeter for the bar, the shortest bar. If you use bar and O-ring, 5 millimeter, and soft tissue for hygiene considerations, at least 1 millimeter. So altogether, 12 millimeters needed, maybe more. An ideal crown height space for implant over denture is about 14 millimeter. Limited crown height space is less than 12. Excessive crown height space is more than 15 millimeters. And they may be. And screw-retained bars helpful to solve angulation problems and limited crown height space problems. And another problem is the fit, the accurate fit of the superstructure, verifying the passive and accurate fit of the superstructure. What is the acceptable level of superstructure misfit? Jen says it should be less than 150 micron. Mish says it should be less than 80 microns. And how to evaluate the accuracy? We should put our fingers at the end and see the end tipping and lateral rocking of the bar on the backward and forward direction. Radiography must be used if some subgingival margins are present. If greater than a half turn is needed here, when you first encounter with the resistance of the screw while tightening. After the first resistance, If more than a half turn is needed to tighten the screw up to 10 to 15 Newton centimeter, it is a misfit. And presence of discomfort or pressure during tightening also indicates misfit. So for long-term survival of implant over dentures, try to minimize the following force factors according to the bone density when fabricating implant over dentures. Cantilever forces and horizontal lever forces. Try to minimize this. Crown height space, which is a vertical lever forces, offset forces, and bruxism. These should be all evaluated with the bone, considering the bone volume and density. And implants and soft tissue supported implant over dentures should have balanced occlusion for less denture movement, decreased forces on the attachments and the implants. Better aesthetic with much ease may be achieved by implant over dentures. And let me show you a couple of cases and some simple procedures here. A simple made-in-office surgical guide to plan and place 2 mandibular implants. I just duplicate the patient's existing denture. Use this procedure only if the denture teeth position and angulation is acceptable, and draw the lines through the canine position and top crestal position, and here you will get the drilling point at the canine position. But I don't convert this into a surgical guide. Sometimes I'm comfortable with using this kind of surgical guide, and when you drill, about 9 to 10 millimeter drill will go into the bone with this type of surgical guide. And here, the guide in place, and 2 parallel implants are placed and sutured. Another simple option is I place gutta-perca on the existing dentures, duplicate denture, and taken Panorex, and I see that this gutta-perca is at the same alignment with the mental foramen. So I make a correction here and the final position, and using this denture as a surgical guide, place 4 implants, and as you see, the foramen is protected. Surgical guides may be more precise if fabricated with the help of CT scan. This is a 84-year-old patient, and maxillary division B or B